Okay, so we will get started. Thank you everybody for joining us here for this wonderful event. Today we are very excited to have Dr. Jack Lin with us to present for the next hour. Dr. Lin, just to give you a quick background, is Professor of Neurology and Biomedical Engineering at University of California in Irvine. He is also the director of the Comprehensive Epilepsy Program, which is a state-of-the-art clinical and research facility here in Orange County, California. And Dr. Lin is also a renowned epilepsy specialist. And at this Comprehensive Epilepsy Center at UCI, they are currently using advanced technologies and therapeutic drug treatments for the diagnosis and treatment of epilepsy. So Dr. Lin, the floor is yours, and here we go.
Well, thank you so much. And I'm so excited to be here. I think that it's remarkable that you all can join me today. Hopefully I can make this more of a open dialogue. So, the chat box will be monitored and then, I'll leave some time at the end for questions and answers. Sounds good? All right. So I will share my slide. Me play this. So the title of the talk is Advances in Epilepsy Surgery. So we have really come a remarkable distance from where we had before. This was one of the early epilepsy surgeries. This was done in Montreal, in Canada. But from the very beginning, we realized that epilepsy surgery is a collaborative teamwork among the neurologists. At that time, one of the pioneers was Dr. Jasper, along with the neurosurgeon, Dr. Penfield, and then a neuropsychologist, Dr. Brenda Milner. And all three of them are in the operating room taking care of the patient, or at the same time, providing the best possible team approach and care. So the epilepsy surgery arena, the surgical arena, really has changed quite a bit. Now we have robots and advanced stereo EEGs and so forth. But nevertheless, all three types of people are in the operating room providing that kind of team approach. So when somebody is being considered for epilepsy surgery, it's not something that we take very lightly. Certainly something that we give a lot of thought to, and after a lot of evaluations with a lot of these tests. And you can see a number of these tests over here. And I'm sure some of you have gone through some of these tests. And what ended up happening is that once all of these testings are done, we sit together as a team with the neuroradiologist, the epileptologist, the neurosurgeon, and a variety of other people, neuropsychologists, and so forth. And we really sit together in this, what we call a multidisciplinary conference, where we talk about your case and really focus all the expertise and attention on a single patient. And then we'll go back and forth, and we're trying to decide what is the best treatment. And sometimes the treatment is medicine. Sometimes the treatment is further evaluation. Sometimes the treatment is surgery, and sometimes the treatment is neurostimulation. So we're really trying to provide a team comprehensive opinion about what should be done. Now, currently there are really two types of evaluation to go under once we decided that somebody is a surgery candidate, but we don't know where the seizure is coming from. If we know, most of the times when we can see a lesion on the MRI or an abnormality on the MRI, and we feel that the location is consistent with the EEG and is not in an area where it could be utilized also for language and for motor and other functions, then perhaps somebody will go straight to surgery. And the most common type of that kind of evaluation was somebody with temporal lobe epilepsy, which is the most common and surgical remediable form of epilepsy. But a lot of times, it's not straightforward and will require more in-depth evaluation to figure out where the seizures are coming from. The epilepsy surgery really has been revolutionized by this type of, sorry, let me go back a second. This type of what we call stereo EEG. And the stereo EEG or SEEG is one of these minimally invasive surgeries where not like the old days where we need to open up somebody's skull, that these electrodes are needle electrodes that can target a variety of different areas of the brain. And this has led to much less complications. So for example, the complication rate for SEEG is in the single digits, essentially. So I'm going to show you a few cases of how we have approached the surgery. And these are real patients with real complicated form of epilepsy. And the wonderful news and the most rewarding aspect of my work is that these people have regained their lives back. They have, most of them have become seizure free, and a lot of them have become seizure controlled, and really has made a tremendous difference in the quality of life. So the first patient is this lady from San Diego that I evaluated now, 5 or 6 years ago. She came from a military family, and her husband is a officer in the military down in San Diego in the naval, in the Navy in San Diego. And but she recently just moved to North Carolina, and so I probably saw her via Zoom telemedicine for the last time. And now, when she first came, she had one lovely daughter, and now she has 3 kids, and she's been seizure free for over 5 years, and it's absolutely remarkable. And so her story, starts with the fact that her seizure starts at age 15, and her seizures starts with a feeling of unexplained sort of feeling that she can't really tell me what it feels like, and many of you probably could feel, could sympathize to the fact that you get a warning of a seizure, but you really can't verbalize what that warning is. Then she has this glassy look on her face. She's unable to talk, and then she'll have convulsive seizures. And that was the most disabling part of this, is that she had these convulsions. She was having these smaller seizures several times a week, and she'll have one generalized convulsive seizure monthly. When I looked at her MRI, in general, if you look at the whole MRI, it looks pretty good. But what was remarkable was the fact that this area where I put the arrow in, the cortex is thickened. You can see it right over here as well. And this is what we call a cortical dysplasia. So essentially, this is a developmental disorder in which as the cells migrate up when she's born, or shortly before she was born, and the layers of the brain are being developed. And you can see, and when the layers of the brain develop, sometimes the certain cells that get arrested doesn't make it all the way to the proper layering. So this is what we call cortical dysplasia, but it is on the left hemisphere. And again, on the MRI, on what you and I see as right is left, and this is the left hemisphere, but it's in a parietal area on the left hemisphere. And that is particularly difficult because that's an important language area. That's an area of the brain that is important for understanding what language, what speech is about. If somebody will talk to you, if this area were to have a stroke or lesion, then a person may have difficulty understanding the content of the speech. And so normally, and we put in a grid over here in that area, and long and behold, I won't bore you with reading the actual intracranial EEG, but what we found was that the seizure indeed came from this area of the brain. But I also did language mapping and realized that from the testing that her language is in this area as well. So obviously she is not a candidate to have that part of the brain taken out as part of the surgery. So what happened was that we actually placed in a responsive neurostimulator, and she just got a battery change after 5 years. And remarkably, she's completely seizure-free from the brain stimulation with absolutely no deficit. So it's this case, show you that if this person and has seen many neurologists, non-epileptologists, they will say, "Well, your seizure is probably coming from an area of the speech," and they're right. So there's nothing we can do for you. But in fact, the responsive neurostimulation has really significantly improved people's quality of life, and we have now implanted over 50 cases at UCI, which is one of the largest in the country. So that's the first case. The second case is again, I get a lot of referrals from San Diego for some reason. And this is another gentleman who's 33 years old, who also is from San Diego. And he was for a period of time living in Arizona. His father is actually a physician, an internal medicine doctor at Barrows at St. Joseph's Hospital in Phoenix. So he would have these episodes in which he will zone in and out of his surrounding, have this nervous sensation in his stomach, and has lost awareness. And he had a seizure by the starting age of 13. And at another institution, he actually had a grid placed over this whole area, and they actually did a resection of that area, and he became seizure-free for probably several months, and then he started having seizures again at a daily to weekly basis. And so at the first glance, his surgery was at a very reputable epilepsy, level 4 epilepsy center. So, so I told him that, well, if, we can't really do any more resection since you already had it, and you already had several evaluations. In fact, he had 2 surgeries, the first surgery and then second surgery, extending this area up to the motor area. So, but the problem is that he was having lots of seizures, and he was end up in the emergency department, probably in San Diego, probably once a month, if not more often. And so, so we decided to use stereo EEG. Now, why do we use stereo EEG? Because he had previous surgery, and if we had to open up and put in electrodes with this, by opening up the skull, there'll be a lot of adhesion and scarring, and it'll be very difficult and probably more complicated. But with the stereo EEG, we're putting these needle electrodes without opening up the skull, we're able to evaluate a large area of the brain. And it turned out remarkably that his seizure actually came from the hippocampus and the temporal lobe, not anywhere surrounding the previous surgery. And in fact, you can see here, this is after surgery. He underwent a right temporal lobectomy, and he has been seizure-free. His mother actually wrote a book, and it's published as one of those books on Amazon. And he went back and got his master's in social work, and now he's a social worker. So really a remarkable gentleman in terms of his pursuit of becoming seizure-free. So the third patient is this 48-year-old woman that came from Corona. And I still remember distinctly this very remarkable lady. She was being evaluated, one of those Friday afternoon clinics I had. This patient actually came to me and told me that, oh yeah, I just started having seizures during New Year's Day, and when I have a seizure, my right arm will go up, and I will start twitching and vocalizing, but I really can't speak. And I said, okay, well, you probably have seizures came from a certain part of the brain. And then he said, well, let me just show you this MRI. When I looked at, lo and behold, there's this circular area over here, and that's a tumor. That's a brain tumor. So I had to really scramble trying to figure out how to take care of her on a Friday afternoon. We actually, so if it was from, outside in the community, she would have just got this area resected. But the key to this case is the fact that often the seizures don't come directly from the tumor, but because if the tissue is abnormal, they're not going to seize. It's actually the surrounding tissue that have seizures. So she underwent a grid placement of this area, and the seizure actually came from an area called the supplementary motor cortex, and subsequently she was evaluated, and we did brain mapping, and she was able to become seizure free with this resection. She did have some weakness as motor planning area, and she knew that when she went into surgery. But then after about a month of rehab, she got up 95% of all of her strength back. She's actually a physical therapist, and she was able to practice again, and she remains seizure free until this day. So really a remarkable story of somebody who's pretty complicated. So what happened if somebody have seizures come from more than one area of the brain? And this is an example of somebody with seizures come from more than one area of the brain. And this is somebody who had seizures came from both temporal lobe, and both temporal lobe look small. And so what ended up happening is that this is an example of somebody with a responsive neurostimulator, and the seizures they're able to detect with this device and stimulate from both sides, and as a treatment. So this is just EEG showing the fact that seizure came from both sides of the hippocampus, and RNS is really not. It's great, but it seldom render people seizure free. So if somebody could be a surgery candidate, it's always preferable. Now, this case illustrates this. So this is somebody came from Las Vegas to see me, and when I saw her, this 49-year-old woman who had, at 6 months she had febrile convulsions, and then subsequently she had multiple seizures. She had a BNS placed in 2011, and she was still having lots of seizures. And when I look at the MRI, this is a classic picture of somebody with hippocampal sclerosis. And so what I thought was, well, that's a pretty straightforward case. This is a typical somebody with temporal lobe epilepsy. Well, not exactly. So if you look at her seizure, this is her seizure that came from the left temporal lobe. And when she has a seizure, she'll hold up her mouth and she'll kind of go up and down. And pretty, dramatic as her seizure. While the right temporal lobe, she had a second type of seizure that came from the right temporal lobe. And with the right temporal lobe, pretty bland. She kind of looks around, kind of put her hand on her head, kind of pounds on her head a little bit, and that's kind of the way that she has them. So pretty different in terms of the two types of seizure. And indeed, on the EEG, you can see that here's the left side, and then this is a left-sided seizure. And then there's the right side, and she has the right-sided seizure. So what do we do for somebody who have both sides seizure? It's a little bit different when you have actually a lesion. This is a the small hippocampus, as we talked about before, something called hippocampal sclerosis. So this is a damaged hippocampus that's of small and probably not very well functioning. So what we did was Dr. Vadera resected this on the left temporal lobe, but putting a responsive neurostimulant on the right side. Therefore, both of these type of seizures were treated. And again, this kind of innovative approach has let her become seizure free. In fact, we're one of the first have done this, and Dr. Badera just published this type of combination therapy where we take out an area that is abnormal visibly on the MRI, but then a second area that is also causing seizures, but we cannot remove using the RNS device. And we've done about 12 of these cases, which is very remarkable. And now a lot of other epilepsy centers have now followed our lead in performing this type of surgery. In fact, Dr. Manasakyan just wrote up a paper with other centers doing this as well, from all the way from East Coast like Yale to us to the West Coast like UCSF. And now this surgical procedure where we do RNS and resection all in kind of the same setting, pioneered by us, has been now widely adapted across the country. So RNS, how effective it is. In the original trial, you can see that it is it leads to about 40% reduction in seizures. But what's really remarkable is that now we have long-term data from this device 6 years out. And if you look at the 50% responder rate, it's about 70%. And the median reduction in the seizure is about 60 to 70% now. Like with other stimulation devices, the longer you have it, the better the outcome. Moving on so we talked about resection, we talked about RNS, but we have not talked about laser surgery, which is another tool that we have. And in the right cases, this could be really, really useful. So this is a 25-year-old gentleman who has had seizures for a long time, since age 6. He has initially, his seizure sounds like come from the temporal lobe because it has this behavior arrest, he has this lip smacking and the hand rubbing automatisms. But then what is really remarkable, and a lot of people, including myself the first time, didn't notice that he makes giggling, laughing sound right before the seizure. So listen to this. Okay, so I hope you guys heard the giggling sound. I don't know if people in the audience have heard of laughing seizures or gelastic seizures, but it is from an area called the hypothalamus, and this is the lesion is right here. It's tiny. It looks like a little grape over here, and you can see on this MRI as well. He had many. He came from Santa Ana, so he's local, but he had many, many high-quality MRIs. All of them have been read as normal. No one really saw this very small lesion. But if you miss it, then you won't be able to find his seizure. And sometimes these people have been misdiagnosed and have the temporal lobe resected wrongly because they didn't see this area of this is a hypothalamic hamartoma. But so this is Dr. Badera again performing laser surgery where there's a laser probe going over here. And again, just a very small hole that was opened up. And then there's the laser ablating this very small area. Now, before laser was available, the way to approach this small lesion is very, very difficult and led to a lot of complications. One approach is to go straight down through the corpus callosum and go down, but you have to open up the top of the skull, and the other is through the nose and approach it. With laser surgery, he came out the same day and he's been seizure-free for more now. This was last year, so he's been seizure-free for more than 2 years now. So it's been just a remarkable outcome, and that's why the evaluation, we have to spend so much time on the evaluation of somebody for epilepsy surgery, because if you miss a tiny little size of a grape, or probably smaller than grape, a kidney being probably this is the size of the abnormality, then something, you will not offer this patient an optimal outcome. Laser surgery has been sort of counted as the new way of doing epilepsy surgery, but we have to remember, sometimes things may sound fancy and sound remarkable, but then we have to temper our enthusiasm and really look at the outcome. If you look at the surgery, this is 2 separate studies. One came from the University of Chicago by Dr. James Tao, and one came from Emory by Dr. Bob Gross. Both of these studies show very similar result, and that is that if somebody for temporal epilepsy, the most common form of epilepsy, if you take all comers for temporal epilepsy, the success from laser surgery is about 50%. Now, if you look at temporal epilepsy with traditional surgery, it's 70% or better. So the likelihood of one becomes seizure-free with laser is still slightly lower than traditional surgery. So one will have to evaluate the pros and cons of laser versus traditional surgery when one considers these, not just because laser is kind of fancy and cool. So last patient I'm going to talk about is this 55-year-old gentleman, came from, again, referred to me from Las Vegas. And he had these seizures where he kind of, with his eyes and head deviated to the right side. So the seizure came from the left side, and then his arm would be tensed up, he would chew, he'd become unresponsive, and he'll have several of these seizures a month. He had tried many medications. He also had tried the VNS. And here is his seizure. You can see he chews, takes a deep breath, lungs. Here now. Yeah. Okay, so again, looking at the MRI is really the key. So he actually was somewhat misdiagnosed when he came to me, because somebody did a quantitative, one of these research MRIs, that his hippocampus is small. Well, it turned out his hippocampus wasn't small, but they wouldn't refer to me if they thought it wasn't came from the temporal lobe, because everyone is sort of afraid of doing surgery outside of the temporal lobe. But what is remarkable is that he had this area in the occipital area, the part of the brain that is important for vision, and he actually had a visual field cut, and you can see that this area is shrunken and small in this occipital lobe. And again, no one noticed this area before. They thought this was just normal. But if you look closely, just look at the MRI, again, this area that is bright, and there are several holes in this area. And this is something called the PET scan, FDG PET, where we inject sugar, radioactive sugar, into the vein and see which part of the brain metabolizes sugar properly. And the area of the brain that that areas that don't metabolize sugar properly, there'll be a void. And you can see there is a void over here with a decrease, less bright, less sugar, decrease uptake in the occipital area. So what it shows us is that that area not only is visibly scarred, but functionally not performing normally. So this is something called eulygyria. It is an area, euly means a Latin term for scarring. So it usually occurs after somebody right around the time they're born of a ischemic injury in a full-term baby, and so what we found is that indeed that's what it is. If we take the pathology, it looks like mushrooms, let me see if I can find an example, can convince you that, there you go. That is in the bottom, the top is okay. And the bottom, the top has more vessels as a baby. So the top is getting perfused on the cortex, but the bottom of the sulcus over here, around it, it gets damaged. And so this thing looks like mushroom body. And hopefully you can see that there's a crown of mushroom and the stem. And it's a pretty common abnormality showing that. So this is eulygyria, and again, he went surgery. So this gentleman actually didn't become completely seizure free. He had a significant reduction in his seizure. He was having monthly seizures, but then after this type of surgery, he was having probably several seizures a year. Every 3 or 4 months, he had a breakthrough seizure, and then there was some adjustment in his medication. And I think recently he's been doing well because I haven't heard from him for the past 6 months or so. So, but certainly it was better than before. So this hopefully gives you a spectrum of surgical options that we have for people with drug-resistant epilepsy. And the idea is that stereo EEG or SEEG has really transformed surgery, where many people who were not surgical candidates before are. And the robot system, the ROSA robot, provides much better accuracy in reducing human error. And there are a whole bunch of other treatments, including brain stimulation with RNS and laser surgery. So hopefully, you will consider some of these options and really take advantage of some of the remarkable advances that we have in epilepsy surgery. So I just want to acknowledge my wonderful team. I'm sure some of you have heard of from my other esteemed colleagues, as well as 2 neurosurgeons that are performing really remarkable surgery. So thank you very much.
Thank you very much, Dr. Lin. That was great info. Appreciate it. And anybody who has a question, feel free to put it in the chat box, or you can go ahead and unmute your line and ask your question to Dr. Lin directly.
People are very shy.
I know, sometimes we have to encourage.
I do get some private chats from my former patients, so that's good.
So we'll give it another minute. Yep, don't be shy. This is the time and place, a great opportunity to be able to ask Dr. Lin some questions.
Hello, Dr. Lin. Hi, this is Zoe. I'm a nursing student. Thank you for sharing your successful surgery with us. It's amazing. I'm wondering how many % of the patient that have this kind of surgery successful. I'm thinking about how many % they are successful.
Well, with temporal lobe epilepsy, the success in terms of the way we grade success is no seizures, absolute seizure freedom, except for ORs, which are not disabling, and that is somewhere around 70 to 80%. For surgery area that are outside of the temporal lobe, the success rate is about 50% of seizure freedom. Now that is a national number, sort of average across many centers. But I would like to emphasize that, in fact, some of our outcomes are probably much, much better than these national numbers. And you can see that, the key is to take sort of innovative approach and treat the patient as a single individual, and brain mapping, precise localization of the seizure onset is really the key.
Thank you. Thank you so much.
And just to point out that, some people say, well, 50 to 70% seizure free and significant reduction in seizure frequency. That's not 100%, but I like to emphasize the fact that if you fail 3 anti-seizure medications, the likelihood of you become seizure free with additional seizure medication is near 0. And so 0% versus 50 to 70% is really remarkable. Oh, it's so remarkable to hear from my own patients more than anything. I can't share them for HIPAA, but they clearly have, some of them have, appreciate the fact that they become seizure free and so forth. And so it's really just really nice to hear. I appreciate it very much. Because, the incredible thing is this, and I say it with all sincerity, that my patient has taught me more than what I give them. That every one of them, their fight, their tenacity, how brave they are of finding a cure is just remarkable. Because I don't know if I could do this as my, if I were to, unfortunately, to have seizures, right? But these people have just showed the I don't know, just so remarkable to see them.
So Dr. Lin, we do have one question in the chat box. Katie has a question. If you have a successful resection and are seizure free for a few years, then start having seizures again, does that reduce your success rate for ever being seizure free?
You can't have a blanket statement whether it is or it doesn't. The key is the fact that probably that person has not had complete resection of the area that causes the seizure. It's impossible to take out the whole area that causes seizure, but there's some critical mass where if you take out enough of it, that somebody becomes seizure free. But then there are other times where you take out not enough, and the person for a short period of time, several years, remains seizure free, but then the seizure occur again. And we have now, then the person will undergo another evaluation with the same detail as I showed you earlier. And we'll find the fact that maybe it's just slightly in an area that is in neighborhood, or maybe another area has become problematic. So it really depends on the situation. I could tell you the patient that we just evaluated, there was an area of the brain that wasn't resected because there was a vessel over it that Dr. Badil didn't want to invade. And it turned out, of course, with all luck, that area started having seizures 2 years afterwards. And then, but this time he went back in after we did intracranial monitoring, proved that area is a seizure area. And he was able to protect the vessel this time, and he was able to resect the lesion. So it's really just that, again, what I emphasize is that we are part of your team. That it's just because we did it, if the surgery has rendered you seizure free, great, go on, be a productive person and do everything that you wanted to do. But if there, in unfortunate cases where there are some problems with it, please come back, and we will, again, use our full abilities to figure out what is going on.
Okay, great, thank you. We've had another question come in. Is there a certain number of seizures you should have per time frame before considering surgery? My seizures started at 22. I'm now 34 and still having seizures, but only complex partial, not secondarily generalized. And at 1 to 3 months, it's still affecting, and 1 to 3 a month, it's still affecting my life a lot. My parents are wondering if there's a specific number before considering surgery.
That's a great question. I think that having, the key is how much does it interrupt your life, and whether there is something that is surgically amenable, and that you can only figure out through a comprehensive evaluation. So to me, and to many others, simple partial seizure where there's no change in consciousness, but somebody just feels in awe, but does not go on to have a full-blown seizure, is less disabling certainly than complex partial seizures, and certainly generalized convulsive seizures are more disabling. So there's certainly to a degree, but nonetheless, people tend to just say, you know what, I have seizures, and there's really nothing we can do, and I guess this lecture I will submit to you that please come to one of the epilepsy specialists and have an evaluation. Really cost you nothing in terms of, except for your time, but you will get all the options. And at that end of the day, you're the one who have to decide whether this is the right thing for you or not.
Okay, thank you. Any other questions or comments or anything you'd like to ask Dr. Lin? Again, feel free to unmute or put it in the chat box. I'll give it another minute here and see. And anything else you'd like to wrap us up with, Dr. Lin?
No, I think that, so just, I think that everyone, the fact that you are here today is just remarkable. And whatever information you passed on, you should pass on to other people with epilepsy, and so that they can find the best treatment for them.
Great. Well, thank you everybody for joining us. Really appreciate you being here, and have a wonderful day and enjoy all the rest of the talks.